with us today, none other than Professor Dr. Shasidharan sir. I'm sure sir does not need any introduction, as sir, he is very, very familiar to each and every one of us. In spite of that, I would like to give a small brief introduction. After retiring as the professor and head of Department General Medicine at Government Medical College, Calicut, sir has been serving as Professor Emeritus Department of Family Medicine at Government Medical College, Calicut, and is currently working as a senior consultant in the Department of General Medicine at Aster MIMS, Calicut. Sir has authored several books, out of which Heal the India is a prominent one, which actually is a collection of his observations on the healthcare system of India. And he also has several publications to his credit, the prominent one being the Association of Vitamin D and Tuberculosis. I would like to welcome you, sir, to this monthly case presentation of Spiceroot Kerala. And
thank you.
And to present this interesting case, we have Dr. Somna, who is actually currently pursuing her first year family medicine, DNB family medicine at Aster MIMS, Calicut. We also have Dr. Serin here with us, who is chair of Spiceroot India. As sir may not be familiar with Spiceroot India, I would just like to give a brief introduction about Spiceroot India. It's actually a movement, a forum for young and future family doctors in South Asia region. The Spiceroot is the Wonka South Asia region working group for new and future doctors who have an interest in family medicine, general practice, and primary care. It aims to promote excellence in this field, in the field of family medicine, and also to address the challenges pertaining to global health. So over to Dr. Somna.
Good evening, all. I'm Dr. Somna, first year DNB resident. I'll be presenting the history of a 50 years old male who's working in a bakery as salesman in Bangalore. His native place is in Kannur. Presenting complaints were loss of appetite and tiredness since last 1 month. History of present illness. He was apparently normal person till 1 month back. Then he developed decreased appetite and nausea. He had decreased taste to food and feeling of fullness while taking little quantity of food itself. And he has increasing tiredness since last 1 month. Occasionally, he has non-projectile vomiting, which contains food particle. 1 year back, he was 67 kg, and now it got reduced to 60 kg. He gives no history of fever or night sweats, no history of joint pain or rashes, no atopic tendency, no history of abdominal pain, no history of yellowish discoloration of urine or discoloration in stools, no history of dysuria, no history of any recent drug intake or blood transfusions in the past, no history of chest pain, palpitation or breathlessness, no altered behavior, no history of high risk behavior. Coming to past history.
Okay, I will, maybe what we can do is, as I routinely do, before we go to past history, let us see what are the possibilities, because the possibilities that you think based on presenting complaints decide what you explore in the past history. So let us see what are the possibilities. 50-year-old male, bakery worker, he started with the insidious onset, decreased appetite and tiredness of 1 month duration. What thoughts should come to us, our mind, when you get that history? Anybody can contribute. It's just an interactive session only. It's not a class or anything. Let us, anybody can contribute. You can unmute and answer, or Somna can answer first.
Tiredness can be due to anemia.
Okay. Which are the other causes for tiredness? When
Can-
somebody comes with tiredness as the major complaint, what all thoughts should come to our mind? Tiredness as the only or complaint or the major complaint?
Anemia, hyperthyroidism,
Anemia, hyperthyroidism.
um,
Why not uncontrolled diabetes?
uncontrolled
Uncontrolled
diabetes,
diabetes.
Hypothyroidism.
Hypothyroidism.
Yeah. Anybody present with fatigue, we should think of endocrine and electrolyte
Yeah,
disturbance.
that is
Endocrine disorders, electrolyte
hypodelism.
disturbance.
Hypodelism.
Yeah.
Hypodelism. Any more?
Chronic
Tiredness.
infections.
Eh?
Chronic infections.
Chronic infections. Neoplasm, malignancy also. And similarly, chronic liver disease and chronic kidney disease. And if all these are excluded, or if there are features of some supportive evidences in history, you will think of anxiety and depression also. So all these are possible causes for tiredness as the major complaint. But here the patient has decreased appetite also, which are the common cause for decreased appetite. Now we'll start combining them. Decreased appetite, which are the common causes we will consider?
hepatitis,
Hepatocellular damage. Most common cause for decreased appetite.
gastritis,
Gastritis is the number one. Then
any chronic infections like tuberculosis,
decreased appetite can occur due to other reasons, but tuberculosis by itself is not a primary cause for decreased appetite, but it can occur as a problem along with that. Again, the same thing can happen with anxiety, depression, hypodelism, renal involvement, liver disease. All these can produce the same symptoms. And tiredness can also be due to decreased cardiac output states. So
congestive
you may
cardiac.
have, it may not be frank congestive cardiac failure. A person with borderline compensated cardiac output may be waiting to develop frank failure, may have tiredness as a cause for decreased cardiac output may present as tiredness also. Anyway, these thoughts should come to our mind along with that. Next symptom that we got is nausea and early satiety. Early satiety and nausea tells what in this patient? And you are non-projectile. You may have to think of hepatocellular damage. Anything else?
Gastric.
Again, gastritis. Acute gastritis or chronic gastritis?
Both chronic.
Both are possible. Anyway, gastritis and even gastric neoplasms also. And non-projectile vomiting also he had got. So, but you said the urine was not yellow.
No.
If the urine was yellow, it could have pointed towards a hepatocellular damage. And there was no abdominal pain. There was weight loss, significant weight loss of 7 kilograms in this period. So what else is a possibility now?
Can be malignancy, chronic infections like tuberculosis.
Then chronic infections like tuberculosis, but there is no fever. Is it against tuberculosis? Not at all. Absence of fever is not against it. Because the commonest symptom in tuberculosis is still weight loss. Fever may or may not be there. Malignancy is possible. Anything else?
HIV infection.
If there is a, that is important because as you go on, if you get a high risk behavior in the past history, you may have to consider that. Anything else? Again, hypodelism comes. Do not forget hypodelism. Renal damage also. Coexisting renal diseases, incidentally occurring, hypodelism, chronic infections, uncontrolled diabetes has to be considered even at this stage. Because gastritis and all can coexist with any common disorders. Or anorexia, nausea, vomiting, tiredness, all can exist with any common disorders due to several other reasons. So when you have significant weight loss, tiredness, you have to consider uncontrolled diabetes also. What other history should have been elicited, which was not incidentally given? When you think of uncontrolled diabetes, what other history will elicit? Do not forget to ask for nocturia, polyuria. Polydipsia may not be there. Instead, they may tell you about dryness of mouth. So ask about dryness of mouth and nocturia along with weight loss. It might suggest an uncontrolled diabetic status also. There was no fever, no arthritis. Okay, so the possibilities are at this stage with the presenting complaints are what? The important complaints are tiredness, decreased appetite, anorexia, nausea, vomiting, and weight loss without fever. Uncontrolled diabetes still is a possibility, but there are no supportive points in history till now. So you still have to consider uncontrolled diabetes. So other possibilities being
Tuberculosis.
chronic infections, HIV if there is a high risk behavior, otherwise tuberculosis. Then do not forget hypoadelism.
Chronic liver disease.
Chronic liver disease, chronic active hepatitis. Low cardiac output states with a thought of if there is some finding as you go on. And suppose this patient had increased bowel movements.
Hyperthyroidism.
Hyperthyroidism also. Increased bowel movements can also occur in hypoadelism. So that's why all that negative history is important here. Like no GI symptoms, no urinary symptoms. When you said no urinary symptoms, you are actually trying to find out whether this patient has got polyuria or nocturia or not. Okay, now let us see the past history.
Past history, he had a road traffic accident 7 years back, during which he sustained fracture over left hand, for which surgery was done. At that time, he was diagnosed to be diabetic, but he was not on any treatment. He was given only diet modification. There is no history of tuberculosis, ischemic heart disease, jaundice, bronchial asthma in the past.
Was any blood transfusions given?
Personal history, his sleep is normal. No history of any blood transfusions.
Okay.
Personal history, his sleep is normal. Appetite already mentioned. Bowel and bladder habits are regular. No history of smoking. Occasionally, once in 2 months, he consumes about 30 ml alcohol, brandy. Diet history, his diet is grossly deficient in proteins, vegetables, and fruits, deficient in meat, and there is no adequate water intake. He takes fruits once daily, vegetables twice daily, consumes fish once weekly, consumes meat once weekly. Family history, there is no significant illness or malignancies in the family. He is unmarried, but he was reluctant to give me the reason. In socioeconomic history, he lives in a well-ventilated room with adequate space, consumes mineral water, good sanitation facility. He is not enrolled in health insurance. Nearest health facility is around 2 kilometers. Summary, 50 years old, unmarried male with past history of diabetes, not on any treatment, now presented with complaints of loss of appetite, tiredness, and occasional vomiting since 1 month, with history of weight loss of 7 kg over 1 year.
What are your provisional diagnosis based on history? You have to give a provisional diagnosis. Can be
chronic liver disease.
Why chronic liver disease?
Non-alcoholic fatty liver disease, like due to diabetes.
Diabetes is not a cause for non-alcoholic fatty liver disease. Is diabetes a cause for non-alcoholic fatty liver disease?
No.
Why is that association? You find the association of non-alcoholic fatty liver disease and diabetes together. Why do they coexist? do not say that diabetes is a cause for NAFLD.
The
Why do they
causes both
coexist?
are same.
Causes of both are same. Both are
Ah.
resulting from over intake of excessive carbohydrate intake, decreased physical activity, because weight gain means fatty liver also. So both are, the causes are same. So they will coexist. Naturally, they will coexist. So you can think of being a diabetic, you can think of coexisting non-alcoholic fatty liver disease. But if he has developed recent onset symptoms, then there could be some precipitating factors. What precipitating factor you can consider in this patient? Can that alcohol be responsible?
No.
It is possible. Even those with liver disease, which are developing liver disease, even if 30 ml per day is enough to upset the balance, you may because not even a single drop is required for normal health. Don't think any amount is safe for the body. So you may get deterioration of the liver function if that patient had been having underlying liver disease, even if it is due to NAFLD. Any other possibility for liver disease? That's why I asked about blood transfusion. 7 years ago, he had a road traffic accident. So even if it is, he did not receive blood transfusion, can he be infected with hepatitis C or B?
Needles.
It is possible. It is possible. That depends on where the patient got admitted. Is it a place where adequate precautions are taken or not? Nowadays, people are taking adequate precaution, but there was a time when the precautions were not adequate. So you can consider that also as one possibility. But you still did not. You still have to consider uncontrolled diabetes as a cause for all these, and that dietary history contributes to what?
B12 folic acid deficiency.
He must be having B12 folic acid and vitamin D deficiency. Why?
Fish intake, meat.
He does not take meat or fish adequately. Obviously, vitamin D he will not get.
Inadequate.
Then B12 also must be deficient because meat intake is only less than once a week. Is the fruits intake adequate? No. So he will have B12, folic acid, and vitamin D deficiency. Definitely. Can these contribute to the symptoms? Yes or no?
Tiredness can occur.
Can some of the symptoms that he told, can these be due to B12 folic acid deficiency? Remember that mucosal damage, mucosal atrophy can occur anywhere in the GI tract, from mouth to anus, including genitourinary tract, and it can include the stomach. You may get atrophic gastritis, atrophic rhinitis, or soreness of the tongue and mouth, or mucosa of the genital tract, rectum, anywhere. So you may get atrophic gastritis also. And that can produce anorexia, nausea, and vomiting. Especially he takes even 30 ml of alcohol, or his diet does not contain enough vegetables and fruits. The things which protect the stomach are vegetables, fruits. They themselves are enough to produce precipitate gastritis. So anyway, you need to consider all these before you touch the patient. But one point which is important is, why is he unmarried? Though he did not reveal, is it important or not?
Yes.
In this patient, why is it important? Anybody? Why is it important? Somehow you have to find out, why is he unmarried? What could be the reason? Somebody has written impotence as a cause. The impotence also is psychogenic more often. Any other reason? High risk sexual behavior. Because unmarried means the chances of engaging in high risk sexual behavior is very high. So you may have to consider, that is why you need to explore the high risk sexual behavior and the reasons for not getting married that can contribute to the possibility of a HIV infection.
Yes.
Diabetic patients need not have impotence. That's a wrong concept. Impotence, if it is there, is due to more other causes. Diabetic neuropathy causing impotence is it is a complication occurring much later due to the autonomic dysfunction. Even that is very often due to coexisting butyl folic acid deficiency. Diabetes by itself is not a cause for impotence. In fact, the other comorbidities are cause for that. And impotence is more often due to psychological problems. That is what point you have to keep in mind. And sometimes endocrine problems are there. Anyway, so you need to consider all these possibilities. And one more thing, why was he using mineral water? Is it something? What are your?
No, he's in Bangalore. So
He is in Bangalore and he is using mineral water. Wherever it is, if somebody says he's drinking always mineral water, what does it suggest regarding our problems? Is it appropriate? Is it expected? Or is it abnormal?
abnormal.
It is abnormal. Nobody should be drinking mineral water regularly because it only shows the pitiable state of our healthcare system. Healthcare system is not hospitals and doctors. Drinking water is still, it is not available to anyone. People have to depend, the tap water is not safe and they have to always boil and that is why they are taking to mineral water. So depending on mineral water for a regular drinking purposes, it indicates the pitiable state of our healthcare. So that you must have concern for that because family doctors must be concerned about these kind of social issues as well. Okay, with this in mind, now we can do a physical examination. What all will you look for? You can think at this point. Can you tell what you will look for? Before you touch the patient, you can predict what are possibilities based on these, and you must be looking for them. And that's what is meant by the statement, eyes will see only what the mind knows. So you have to now prepare your mind to look for certain things. Which are those things?
Features of hypoadrenalism.
You will look for features of hypoadrenalism. Then
Signs of chronic liver disease.
signs of chronic liver disease.
Then any skin manifestation for uncontrolled diabetes, like
Uncontrolled diabetes has no definite skin manifestation. You have to look for nutritional deficiencies, butyl folic acid deficiencies, vitamin D including, Chvostek sign you can look for. And anyway, signs of chronic liver disease you look for, pallor and hyperpigmentation of the skin you can look for. And signs of chronic liver disease, what will you look for?
parotid enlargement.
Parotid enlargement is not a usual sign of chronic liver disease. And if at all, it is seen in chronic alcoholics with liver disease. What else?
Gynecomastia.
Even gynecomastia is not a common sign of chronic liver disease. Much later, and it will be there, but a very far advanced chronic liver disease only will have it. Earlier signs are more, earliest abnormalities you have to look for.
Loss of body hair.
Loss of body hair also is not a feature of chronic liver disease.
Dry lustreless skin.
Dry lustreless skin. The skin becomes dry lustreless, white nails. White nails, dry lustreless skin, and sometimes pigmentation abnormalities, and a firm hepatomegaly. These are sure evidences of chronic liver disease. If there is a firm hepatomegaly in this patient, you can anticipate chronic liver disease. Shrunken liver also indicates. If there is splenomegaly, in addition, you may think of a portal hypertension. Anyway, look for those. Spider nevi, do not expect in everyone. Even alopecia is not a sign of chronic liver disease. Alopecia is hair loss is not a sign of chronic liver disease. Spider nevi occurs in chronic alcoholics with liver disease, not in non-alcoholic fatty liver disease. You will not find spider nevi in other patients with chronic liver disease. Anyway, and you need to look at the chances of developing non-alcoholic fatty liver disease by looking at the BMI. Okay, now let us see the physical findings.
General examination, he was conscious, oriented, lethargic, height 169 centimeters, weight 60 kg, body mass index 21. No pallor, icterus present, no cyanosis, clubbing, no pedal edema, knuckle hyperpigmentation was present. Bilateral anterior and posterior cervical nodes were palpable, 1.5 centimeter in size, firm consistency, mobile and non-tender. Skin over the nodes were normal, and bilateral anterior axillary nodes were palpable. Right single node 2 centimeters and left multiple nodes, largest measuring 2 centimeters, which was firm in consistency, mobile and non-tender, and skin over the nodes were normal. And bilateral superficial inguinal nodes were palpable, 3 centimeter, firm in consistency, mobile, non-tender. There was no local rise of temperature over the nodes, no sinuses or discharge. He had dry, lusterless skin, white, brittle nails, no thyroid swelling. He was clinically euthyroid, and there was no other signs of chronic liver disease. Vitals, pulse rate 90 per minute, regular rhythm, normal volume and character, no radiofemoral delay. All peripheral pulses equally palpable on both sides. Blood pressure 130/80 millimeters of mercury in right arm supine position. Respiratory rate 16 per minute, abdominothoracic, febrile. Gastrointestinal system examination. On inspection, had good oral hygiene. Shape of abdomen was normal. Umbilicus centrally inverted. All quadrants moving equally with respiration. Skin over the abdomen normal. There was no dilated veins or surgical marks. On palpation, no local rise of temperature or tenderness. Liver is palpable 8 centimeters below right costal margin in midclavicular line, and left lobe 7 centimeters below sternum. It was non-tender, firm, with regular surface and sharp borders, moving downward with respiration. Spleen is palpable 5 centimeters below left costal margin, non-tender, firm in consistency, moving with respiration. No other mass palpable, no fluid thrill. External genitalia and hernial orifices were normal. On percussion, upper border of liver dullness in right fifth intercostal space in the midclavicular line. Liver span 17 centimeters. Crop space was dull, no shifting dullness. On auscultation, normal bowel sounds heard, no bruit heard. Cardiovascular system, jugular venous pressure not elevated. Apex beat palpable in left fifth intercostal space, 1 centimeter medial to midclavicular line, normal character. No thrill or parasternal heave, no palpable pulsations. First and second heart sounds heard normally, no murmurs. Respiratory system, trachea central, shape of chest normal. Movement of chest was equal on both sides. Chest expansion normal. Normal vesicular breath sounds heard in all lung areas. No adventitious sounds heard. Nervous system, higher mental functions were normal. Cranial nerves examination within normal limits. Motor and sensory system examination within normal limits. No cerebellar signs. Gait normal. Skull and spine normal.
Okay, now summarize the important physical signs.
He had icterus and generalized lymphadenopathy, and there was features of B12 folic acid deficiency. Knuckle hyperpigmentation was present. Then brittle nails, white brittle nails, and dry lusterless skin was present. And
so he has some features of chronic liver disease. He has features of B12 deficiency and hepatosplenomegaly and lymphadenopathy. That lymphadenopathy is significant or not?
Yes, significant.
Significant. Now give a differential diagnosis based on all these. Provisional diagnosis.
Non-Hodgkin's lymphoma.
Because of the generalized lymphadenopathy, you cannot hold on to tuberculosis as a cause. Can you get a generalized lymphadenopathy in tuberculosis?
No.
Not at all. In an adult, you should not think of tuberculosis as a cause when you have generalized lymphadenopathy. Generalized lymphadenopathy indicates some other disease. So one is non-Hodgkin's lymphoma. Any other possibility? What is that jaundice suggestive of? Yes, jaundice. And you also said about, because we don't have the patient with us, you said that he has knuckle hyperpigmentation. Suppose he has got B12 deficiency. Is there any other reason for the jaundice? Okay, somebody has written dyserythropoiesis. So jaundice may be due to dyserythropoiesis. In that case, it will be an unconjugated bilirubin. It all depends on the size of the lymph node. You said 1 to 1.5 centimeter. If that lymphadenopathy is not there, everything else can be explained by the chronic liver disease, portal hypertension, and B12 folic acid deficiency. Can you get splenomegaly in B12 deficiency? Can you get splenomegaly? Yeah, it is possible because of the dyserythropoiesis. And jaundice also can occur. So the problem is the generalized lymphadenopathy. How significant is the generalized lymphadenopathy is a very important deciding factor to think of NHL. It was in the posterior cervical group, axillary, inguinal. The lymph nodes were there in the, it depends on the size of the lymph node, 1 to 1.5 centimeter.
Anterior cervical as well as posterior.
Was there any supraclavicular lymph nodes? Was there any epitrochlear lymph nodes? If epitrochlear is there, supraclavicular is there, definitely they are abnormal. But even otherwise, this much of generalized lymph node enlargement of this size cannot be ignored. So you need to consider NHL, but it may the jaundice and fam hepatomegaly, splenomegaly can still be due to other reasons. Can you get jaundice in non-Hodgkin's lymphoma? Can you get jaundice in non-Hodgkin's lymphoma? Yes or no? Anyone? You can get hepatic infiltration, infiltration of the liver by NHL can produce it. Even Hodgkin's disease can produce granulomatous involvement. Anyway, if the entire thing is due to NHL, you can explain it. But again, the possibility of chronic active hepatitis due to a viral infection or HIV infection also is still there. And an autoimmune disorder, finally, don't forget that. Can lymphadenopathy occur as part of autoimmune disorder? Do not forget other causes if lymphoma is not there on investigation. That is why we need to consider them. If on evaluation, you don't find any evidence of lymphoma, you may have to think of other possibilities. That's why I'm thinking about HIV infection and autoimmune disorders. Do not forget that before you go to investigation. Okay, let us see the investigations now. The jaundice can indicate chronic active hepatitis in this patient. Or if it is unconjugated, think of B12 deficiency. Somna? Hello? Dr. Somna? Not there. Hello?
Sir, I think she has lost connection.
Okay. So, is she joining immediately or
Yes,
should we wait?
yes, sir. Yes, sir.
She has come.
I'll just call her, sir.
Okay, we'll wait for 5 minutes then. Hello. Somna, come back.
Sir, no, I didn't get her over phone.
Okay. Meanwhile, as she joins, we can think of the investigations that we will do, which will lead to a diagnosis.
Okay. Sir.
Okay. Anybody can contribute, and how do we proceed from here? How do we proceed from here? I'm trying to contact her. Okay. Okay. How do we proceed from here to evaluate this patient? What do we need, and how will we interpret the abnormalities? Anybody can suggest. We can just have a discussion on that. First investigation that you will prefer. You should start with what? Hello? Nobody's hearing. How do we proceed to investigate this patient?
Sir, I will go with complete blood count with ESR.
That will be the first thing to do. Complete blood count, ESR can tell. Sometimes you may find that the patient has a chronic lymphatic leukemia. So that complete blood count can with a lymphocyte predominance. And if the ESR is very high, it can even suggest an autoimmune disorder. So complete blood count will also give some clues regarding the possibility of B12 folic acid deficiency, like MCV on the higher side can suggest, or bone marrow infiltration can also be suggested by the possibility of low hemoglobin thrombocytopenia or leukocytosis or leukopenia. So complete hemogram is the most important primary investigation. After that, we will go to next investigation will be what?
So can it be peripheral smear to look for abnormal cells?
That is only after hemogram. If the hemogram shows some clues towards a bone marrow infiltrating disorder like CLL, then you will look for a peripheral smear. Otherwise, without a hemogram, peripheral smear should not be. After seeing the hemogram, we can consider peripheral smear. Not at this stage. Let us see the hemogram. Then we will decide peripheral smear is needed or not. What next? Peripheral smear we'll discuss after seeing the hemogram. We will decide after seeing the hemogram. What next? You remember the patient? Patient had
liver function test.
liver function test. Albumin, that is it. Albumin globulin ratio, liver enzymes. These are very important now. And even alkaline phosphatase. Because you got a jaundice, if there is an infiltrating disorder, alkaline phosphatase may be elevated. Even otherwise, vitamin D deficiency can produce elevated alkaline phosphatase. So SGOT-PT, serum protein, alkaline phosphatase is the next most important investigation. Rest of it depends on these results. There's no point going further before seeing hemogram and liver function test. Let Somna come back and give those results. Has Somna come back? What happened?
No, sir, she's not reachable also over phone.
That is what I also tried.
സാറ് വിളിച്ചിരുന്നു എന്തോ കണക്ഷൻ പോയതാന്ന് പറഞ്ഞു ട്രൈ ചെയ്യുന്നുണ്ട് സർ.
Try ചെയ്യുന്നുണ്ടല്ലേ? So because without knowing the results, we cannot. Anybody else knowing the reports?
Sir, I'll check, sir.
Please.
The person you have called is speaking to someone
Hello, Somna join you. Connect ആവുന്നില്ല അല്ലേ? നോക്ക റിപ്പോർട്ട്സ് നോക്ക് വേഗം ട്രൈ ചെയ്യും കേട്ടോ. ശരി, ശരി. She is not able to connect. Fasna, can you find out the reports?
Yes, sir.
Please give the hemogram first.
Sir, complete hemogram, hemoglobin 14.7 gram per deciliter. Total count 18,400 per microliter. Platelet count 2.78 lakhs. RBC 5.7. PCV 45.4. MCV 89.5. RDW 15.5. Total count I told 18,400. In differential count, neutrophils 30%, with lymphocyte 56%, eosinophil 1%, monocyte 13%, basophils 0.
So what? Okay, well, let us stop at this. Let us have a
Referral smear showed normocyte.
No, not us. Let us think of the peripheral smear should not be discussed at this stage. We need to know what are the possibilities based on the hemogram. Hemogram does not include peripheral smear always. Hemoglobin is normal. Total count is 18,400. What is your diagnosis based on this hemogram? Anybody can contribute. Anybody? You don't need a peripheral smear to make a diagnosis. It is obvious from this hemogram. What is it? Anybody? Can anybody? You can make a guess. You don't worry about going wrong.
Here there is lymphocyte predominance, sir.
What are the possibilities? What will you suspect? Somebody has done drug-induced lymph node enlargement, rheumatoid arthritis and Still's disease. These are unlikely because the patient does not have arthritis as a predominant symptom. Still's disease also presents with prolonged fever as a problem. If that patient had been on a prolonged intake of phenytoin sodium, you can think of drug-induced lymph node enlargement. HIV status, HIV will not produce this kind of response. HIV status you will look for because it can coexist with all the problems. Any other possibility? With this hemogram, what will be your first clinical diagnosis? This is an important hemogram. You have total count is 18,480. Is it normal?
No, sir. There is proliferation of
lymphocytes. And is it an acute leukemia?
No, sir.
Because, it is not. Is it an infection?
IMN like.
IMN like infection can have symptoms like fever to begin with. So at this stage, you should not consider IMN. But if suppose it's a child with prolonged persistent fever, lymphadenopathy, pharyngitis, rash, you may think of a leukemoid reaction of a viral infection. But this is an adult with no febrile illness, nothing to suggest IMN clinically. When it is not suggestive of IMN clinically, one should not entertain IMN as a first possibility. What else? Is it an acute leukemia? When you have unexplained lymphocytosis, always think of leukemia. Blast also can be counted as lymphocytes in an autoanalyzer. Blast can also be counted as lymphocytes in an autoanalyzer. So you may think of acute leukemia as a possibility. That's why I asked about, will you think of acute leukemia with this hemogram? Yes or no? You should not think of acute leukemia because the platelet counts are preserved. In acute leukemia, the first thing to come down is platelet count. Hemoglobin may still be remaining normal for some time because of the long half-life. So you cannot think of acute leukemia with this hemogram. So what is remaining? So anyway, it is a neoplastic disorder involving the bone marrow, and it is chronic lymphatic leukemia. The clinical picture together gives a clinical diagnosis of chronic lymphatic leukemia. This is how they present sometimes. The total count need not be very high. Unless there are other explanations as we go on. Now the peripheral smear is very important here. Peripheral smear showing mature lymphocytes tell about a possible CLL. If it is atypical lymphocytes, you are right. You can think of IM and HIV. All these you can consider. Anyway, peripheral smear no. First now peripheral smear
Sir, peripheral smear, normocytic normochromic blood picture with 45% atypical lymphocytes, 45% lymphoid cells with abundant cytoplasm, round to intended nucleus, and occasional prominent nucleoli. Numerous smudge cells seen.
So what is their conclusion finally?
There is 45% atypical lymphocytes. There is presence of smudge cells, so we can think of chronic
lymphatic leukemia.
CLL also.
So the hemogram and the clinical picture, overall picture favors Somna vannittuണ്ടല്ലോ CLL can be considered. Okay, you will think of CLL at this stage, even if the total count is not very high. But you still need to rule out leukemoid reaction type due to a viral infection because atypical lymphocytes are reported. So you need to look at other markers for clonal markers for CLL. That is another thing. Or bone marrow sometimes may have to be done. Anyway, you have to consider CLL. Smudge cells are very suggestive of CLL only. Clonal markers may be required. Immunohistochemistry may be required to diagnose that. Anyway, at this stage, family doctor may not be managing the patient. The patient may be referred to somebody who is interested in managing that situation. Anyway, the liver function test, Somna.
Yes, sir.
LFT.
LFT. Showed SGOT higher than SGPT.
SGOT is how much?
SGOT.
First now also has a report, no?
Sir, 68.
SGOT 68, SGPT?
SGPT 31.
31. And serum protein?
6.7.
Albumin?
3.
Globulin? 2.9. Total protein 6.7.
Globulin
337. 6.
Total protein 6.7.
Yes, sir.
Albumin 3.8. So the globulin is 2.9, isn't it?
Albumin 3.6 and globulin 3.1.
6.9 ano?
Albumin 3.6 and globulin 3.1.
3.1. Anyway, there is no reversal.
No, sir.
Anyway, SGOT more than SGPT in this clinical setting tells you what?
Autoimmune disease.
You have to think of an autoimmune disease. So which autoimmune disease can have liver disease? But again, the hemogram does not support it. Alkaline phosphatase is how much?
337.
337.
7.
So now you have to suspect a granulomatous hepatitis. Granulomatous hepatitis. And in this patient, you have to think of granulomatous hepatitis can occur in Hodgkin's disease. But Hodgkin's will not produce a lymphocytic predominant kind of. So liver infiltration by CLL is still possible. NHL is possible. That's what still we have to consider. But CLL itself can coexist with autoimmune disorders. So we may have to consider autoimmune disorders and chronic lymphatic leukemia as a final diagnosis. So ANA profile, HIV screening was done?
Yes. HIV, HBsAg, HCV is negative.
Negative. And what was the any other investigation done? ANA profile?
No, sir. ANA profile is not done.
Okay. What is the final diagnosis arrived at now? Or is it still under investigation?
No, non-Hodgkin's lymphoma.
Confirmed.
He was given CHOP regimen treatment.
Remember that non-Hodgkin's lymphoma with this presentation is chronic lymphatic leukemia. Because what is the difference between lymphoma and leukemia?
Lymphomas, lymphoid malignancy affecting mainly lymph node.
The neoplastic cells are confined to the lymphatic system. When it spills over into the blood, it becomes leukemia. So now at this stage, even though you call it as NHL, it is chronic lymphatic leukemia. The diagnosis has to be chronic lymphatic leukemia. In fact, small lymphocytic lymphoma is the finding that you get in. If you do a lymph node biopsy, you will get the diagnosis of NHL. But peripheral blood, if it shows this thing, it is definitely a chronic lymphatic leukemia. Was immunohistochemistry done?
No. Immunophenotyping was done.
What was the finding?
It revealed 45.7% abnormal T cells neoplasm, CD4 positive with loss of CD7.
So it is a T cell neoplasm. Okay. It is all the more abnormal to get a T cell lymphoma. But T cell lymphomas can be sometimes due to unusual viral infections, HTLV. So these are some possibilities we need to consider. ANA profile has to be done anyway. Just to think of an atypical presentation of an autoimmune disorder, because some of the autoimmune disorders can progress to neoplasms later. And anyway, up to this, and what is the bilirubin level?
Bilirubin 1.9. Total bilirubin 1.
Total bilirubin 1.9, you will not get jaundice.
Mild icterus was present.
But you said jaundice.
Icterus present.
Icterus present, you should not tell when you are not sure of it. That is one problem that you have to keep in mind. Jaundice, when you say, it should be jaundice. Otherwise, you don't even mention it. In this patient, if you mention jaundice, it leads to a different diagnosis. That is why I was still focusing on chronic liver disease and autoimmune disorders. The jaundice has been misleading us. The jaundice should not be, it depends on your perception of jaundice. Why did you say there was jaundice? Definitely, you said jaundice was present.
Discoloration was present in the.
No. You have to verify, how do you verify if you are doubtful? When you say jaundice, it has to be there. or at least after verifying the serum bilirubin, you can go back and check, and when you present again, you should delete that finding, because there's no point misleading the discussion. Okay. After this, after seeing the report, did you examine again? Sometimes you may get a subjective
Yes.
feeling. Sometimes
There
you may
was-
get a subject. There was jaundice. Still there was
Yes,
jaundice.
sir.
Who else has seen first now? Was a jaundice?
Jaundice was there. The next day report came bilirubin 2.3.
But what on examination was jaundice present or not? If it is there, you are not wrong. I'm not telling that you are wrong.
Not that significant.
No. If you got jaundice, the interpretation is patient has betel deficiency. Okay. That is the point I'm trying to say. The patient must be having betel deficiency, because you get slight unconjugated bilirubin. As you get in hemolytic jaundice, you will get some elevated bilirubin. So if you have jaundice and if the bilirubin is 2.5, you can think, and if it is unconjugated, you can think of dyserythropoiesis due to betel deficiency. That is another possibility. Anyway, any other point to discuss? Any other queries?
Sir, HLS is possible. Possibility of HLH.
HLH is not possible. HLH presents in a entirely different presentation. HLH will present like elevated liver enzymes, cytopenia. What was the ESR in this patient?
10.
ESR was 10. How much was
Yes, sir.
ESR?
ESR was 10.
10 only. So that may make you suspect whether there is an HLH or not. HLH, you will get cytopenia rather than leukocytosis and lymphocytosis. If that patient had an unexplained liver enzyme elevation, cytopenia, falling ESR, you may suspect it. But in this patient, HLH is unlikely, because lymphadenopathy is usually not a presentation. Lymphocytosis also is usually not a presentation. But once you suspect, you have to do a bone marrow and look for macrophage with erythrophagocytosis. Erythrophagocytosis can be looked for. Ferritin can be looked at. Anyway, it is unlikely to be HLH. Any other possibility? Any other point? Any other point to be discussed? Anything else to be discussed? Dr. Serene, Dr. Ali, Dr. Mamta, anything else to be discussed? I hope this is all what you expected, no?
Yes, sir.
Because there is no point going further, because it is a case discussion. It all depends on what is the diagnosis that we arrive at. And if at all, the discussion is on NHL management, which is not a concern for family doctors, but you should know how they are managed. That is all. How just the medicines used and the duration of treatment, that alone is necessary for general practitioners or family doctors. Okay, anyway, you will not be directly managing these patients. And the treatment given was R-CHOP.
No, CHOP regimen.
CHOP only, okay. Because rituximab is used only when it is CD20 positive. That's why CHOP alone was used. It is diagnosed as T-cell lymphoma, but clinically it is a T-cell CLL. The diagnosis should have been more appropriately T-cell chronic lymphatic leukemia. Usually it is B-cell CLL.
Common.
Here it is T cell CLL. Any other point?
I think there are no more questions.
Okay, we can conclude then. Thank you for inviting me to discuss. Thank you.
Thank you so much, sir. So, thus we have come to the end of the session. Firstly, I thank our beloved mentor, Dr. P.K. Shaziran sir, who took time off his busy schedule to moderate this session. I'm sure for many like me, it was bringing back memories of our post-graduation days. We really miss all our case discussions. Thank you, sir, and we hope to see you again in our future sessions as well. On behalf of Spice Route Kerala, I thank you, sir, for moderating the session. I also thank the presenters, Dr. Somna and Dr. Fasna also, who presented the case very well. I thank our state chair, Dr. Ali Zamil, our national executives, Dr. Turiakos and Dr. Jyotika Gupta. I also thank our senior leaders, Dr. Rashmi Kaimal, and all others participants who were present today. It is the academic sessions we have, we are planning to have every month. And for the next month, we have takers from the residents of family medicine from Calicut Medical College. The date will be intimated later. Thank you all and good night.
Thank you. Tomorrow we will have the family Department of Family Medicine is having that discussion on clinical approach to seizures. I hope.
Yes, sir. From
Okay,
Department of Family Medicine, I invite all of you to attend that session. It will be very useful to all postgraduate students and also working people also.
Thank you. Good night.
Link will be shared in Spice Route group.
Thank you.
Thank you.
See you.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.
Thank you, sir.